Diagnostics. Hello, everyone, and welcome to Testing for Divergent Strains with Dr. Amanda Elam. Dr. Elam is CEO and co-founder of Galaxy Diagnostics, an early-stage medical diagnostics company based in North Carolina, advancing diagnostics and clinical discovery for emerging infectious diseases like Lyme disease and cat scratch disease. In 2021, she served on the Diagnostics and Tick Ecology subcommittees for the Federal Tickborne Disease Working Group, and has subsequently shared presentations addressing bottlenecks in the National Innovation Pipeline for advancing diagnostics in the field of emerging infectious disease. Dr. Elam is also a research fellow at the award-winning Diana International Research Institute at Babson College, where she conducts research on gender and entrepreneurship around the globe. She holds a doctorate in sociology from UNC Chapel Hill. So thank you so much for joining us today, Dr. Elam. I want to go ahead and start by introducing Galaxy Diagnostics. So obviously, as I mentioned in your bio, you're CEO and co-founder. So what made you want to become a founding member of Galaxy Diagnostics?
Right. So I guess that's where personal meets professional, right? So I was actually teaching entrepreneurship at the College of Management at North Carolina State University. And I met, through a friend, I met two co-founders at the College of Veterinary Medicine, Dr. Ed Breitschwert and Dr. Ricardo Maggi. And two scientists, they're working on advancing research and diagnostic development for very hard to detect bacteria, specifically Bartonella species. And they had developed this technology, patented, and it was really driving a lot of discovery in their research. And they wanted to find a way to get it out there for clinical use, initially among veterinarians, and then eventually we figured out how to make it available to providers and human health as well. So yeah, so I was teaching and I met them and they explained the challenges and said, can you help us? And I agreed to work with them to launch a laboratory and start figuring out the market and how it might be useful to veterinarians and clinicians.
That's very cool and sounds like a nice story. And the fact that all of you are still working together to this day is really great. Did you happen to have a personal relationship with tick-borne disease prior to this, or they just happened to come to you because of your business acumen?
No, I knew nothing really at all about tick-borne illness. I mean, I live in North Carolina and I knew we had Rocky Mountain spotted fever and Lyme disease in the mountains. And I mean, I'd heard what everyone else had heard sort of from public health, and I do a lot of backpacking and hiking and camping. I'm a happy alumni of the North Carolina Outward Bound program many years ago. And so, so I paid attention just because I love the outdoors. And my kids were in scouting and camps and stuff like that. So I knew about tick checking, knew to be aware, knew to pay attention if there was exposure, to look for symptoms and then go to the doctor if there was a summer flu or something like that going on. But nothing alarming. And for what I'd learned is what I think we all had learned, right? That Lyme disease is an acute infection and it's easily treatable with antibiotics. The trick is to get to the doctor soon. And I didn't know anything about the diagnostics. I didn't know anything about treatment failure. I had no idea about the complexity that is Lyme disease or tick-borne disease. And of course, with my co-founders at NC State, we started with Bartonella, which is really known as a flea-borne disease or louse-borne disease. So I kind of came to tick-borne disease through Bartonella.
That makes a lot of sense. And it's actually refreshing to hear that there's somebody else who isn't a patient themselves in the industry. I myself am not a patient either, but have a background in the nonprofit world and, have ended up now managing Project Lyme. So cool to see that there is other people. And quick shout out for all of our attendees. Speaking of backpacking, Project Lyme will be featured on Backpackers Radio in about a month from now. That's a podcast that we'll be discussing hiking and tick safety on there. So keep an eye out to listen to that. But so moving forward, you had just briefly mentioned that, and it was also included in your bio, but it seems like tick-borne disease is not the only disease that the lab is testing or focusing on. Is that correct?
Right. Well, we started with Bartonella infection. And it's a complex, genus of bacteria and associated with various disease states and similar non-specific symptoms and questions around persistence. So we started there, and it became pretty apparent that Lyme disease was very similar from a clinical perspective. Like when a patient shows up in a doctor's office, how does the doctor know? Other than risk factors, but doctors don't usually ask about risk factors. Now in North Carolina, they might ask about ticks, but they won't ask about fleas or lice or other vector exposures. And so we were kind of drawn into the tick-borne disease world, frankly, Noah, by disease advocates like you, like professionals who were running nonprofits and saying, a lot of our doctors say that, the Bartonella is implicated in some of the cases. And it's a very complex problem set, right? Because Bartonella were discovered much more recently in North America in 1990, or rediscovered as the causal agents of cat scratch disease in HIV patients, so severely immunocompromised patients. And so that's where that research all kind of took off from there. And so, and Borrelia was discovered much earlier. So there's a big question whether, Bartonella is a problem in Lyme patients because they're both in the tick that gets transmitted, or if maybe people are already colonized with Bartonella, it's an opportunistic infection. And when they get Lyme disease, they become immune compromised, and then Bartonella goes crazy, right? And so there's a lot of complexity around it, but that was the original draw from disease advocacy, is we think Bartonella is playing a role. Our doctors think Bartonella is playing a role in Lyme and tick-borne diseases.
Yeah, I mean, you definitely laid it out flat there, that we know clearly that a lot of these diseases are hard to diagnose. So that's where kind of Galaxy Diagnostics has come in and look to address those issues for the patient community. So
right.
According to your website, clearly you focus on Bartonella and Lyme disease, but I was curious if you could outline more specifically what those tests are and how they may be made available to patients.
Right. And so we've been around for 14 years, right? So we're not a new kid on the block. We have spent most of our time sort of in stealth mode, because our focus was really on identifying the technologies that could be mainstreamed into medicine to advance direct detection for these agents. And we started with Bartonella, we went to Lyme. We're interested in other flea and tick-borne agents. We're actually interested in other bacteria that share some of the same properties. They're stealth pathogens, they fly under the radar, they're very difficult to document in patient samples. We have now identified those technologies. So, and we have really, we have the two sort of leading tests, one for Bartonella and one for Lyme disease. So the Bartonella testing is what we call Bartonella digital ePCR. So the NC State team had developed this proprietary enrichment media called Bartonella alpha proteogrowth growth media, or BAPGM, which a lot of people hate the name, but that's what they named it. And that's what has kind of stuck around. But using sort of this enrichment step, the sample enrichment step, it's allowed us to go beyond the limits of simple DNA testing. So originally we paired BAPGM with PCR, and then advances in molecular detection have brought us digital PCR. Still new, still baby. I think we've got the first codes in infectious disease ever for the reimbursement codes for digital PCR. And it is increasing sensitivity of detection by 6 to 10 times based on the research we've published so far. So really exciting, right? And now we haven't applied that to Borrelia just yet, because Borrelia burgdorferi doesn't stay in the blood, but there are some relapsing fever Borrelias and certainly lots of other pathogens that may be of interest to apply that technology. And then we have a second technology that was actually developed by scientists at George Mason University, and that's the nanotrap technology. It's been commercialized by Series Nanosciences, who create the actual nanoparticles, but same concept, right? You're taking the sample and you're enriching it prior to confirming whatever your target is. So the initial assay is the Lyme Borrelia nanotrap urine antigen test. So we're looking for a very specific surface protein that is well conserved across species of Borrelia called the OSP-A. So it's the outer surface protein A. It tends to stay, it tends to be present throughout the duration of infection too. And this is really, urine was never considered a good sample for documenting infection in, but now that we have this ability to sort of magnetically, this affinity capture, but capture the target protein, spin it down to concentrate it, and then confirm whether it's in the concentrate, it's really revolutionizing the ability to confirm active or current infection with Borrelia. And I'll tell you, a lot of people ask, why urine? And there are a lot of researchers and practitioners out there who don't understand why nanotrap in urine works. And the answer for Borrelia, and the answer is microbiologists, when they're running all of the mouse models for Borrelia infection, have known for a long time that Borrelia tend to aggregate in the bladder. So while it may leave the blood, it tends to migrate to the joints or to the bladder, possibly to the eyes, to different areas of the body, where if we can come up with diagnostic techniques, it can be very effective, as the GMU team has demonstrated. Again, nanotrap capture of antigen in urine is very promising. So we're continuing to develop these technologies. We're going to apply them to other targets, working with the development teams, and we're just really excited that we've got these assays, we've got reimbursement codes behind them, we've got them out there in the hands of doctors, and it's going to solve a lot of the controversy that's generated by antibody testing. And I'll pause there because you might have questions about that problem set, right?
Yeah, I definitely have a couple of follow-up questions to everything you just outlined, but you obviously went a little bit into the specifics of how the tests work. And it seems like from what you were saying, you're looking to apply it to some other existing tick-borne diseases, including Babesia and Rickettsia, or are you not currently looking to expand there?
Yeah, we have. And we've got one publication on the digital PCR, the BAPGM digital PCR side, where we've actually developed a multiplex version of the ddPCR. So again, the digital PCR technology is still young, but it's multi-channel, and it's going to allow us to run one test and look for multiple targets. And so we published a paper showing how we could do this for Bartonella, Borrelia, and Babesia. So a proof of concept paper, and we demonstrated analytically and also in clinical samples, we were able to demonstrate that we could document, the presence of DNA, which there's very, very promising advances.
That it definitely sounds very exciting. I'm sure all the patients that are currently watching live feel the same. At this point, obviously you're making a lot of progress, but I know that from some research, it states that existing tests, not including Galaxy, would sometimes only have a 50% accuracy rate. So obviously there's no expectation that you might get to 100%, because I don't know if that exists anywhere. But what are some barriers to that, and how are you working around that through your research?
No, well, that is a great question. And, and one question I really want to get out, not only to the patient community, the advocates and clinicians, but also out to researchers, because there are a lot of researchers in infectious disease who think, well, PCR is plenty sensitive enough. Why can't we just use that? And the answer is, we're dealing with a class of infectious agents that are not like most of the infections we deal with in human medicine. These are called stealth pathogens for a reason. And that is that they don't have sort of this frontal, there's that military metaphor, the frontal attack strategy. They don't have giant armies they're sending in, and they're replicating and overwhelm you, like an E. coli infection or staph or strep or something like that. These are pathogens who infect at really low level, and they replicate very slowly. So they grow very slowly. So Bartonella has a doubling time of 24 hours, right? So E. coli has a doubling time of 20 minutes. Just think about that. So in 2 days, you have a lot of E. coli in the body, like, that's 37 million trillion, whereas with Bartonella, you're still going to be under 20. So it's kind of like, we have to think about this, and these these pathogens and what their pathobiology is, how they infect the host and how they move in the host body, to really understand what the best diagnostic strategies are for these organisms. And so that's something I want everyone to understand. The biggest technical challenges are how these organisms behave in the body. And that's why they've been able to persist for thousands of years and continue to, infect the animal reservoirs and people, because they're stealthy. They fly under the radar.
Well, your mention of persistence, I think, is a good segue to my next question, which obviously an issue with this disease, aside from the slow multiplication of the bacteria, is also the fact that if somebody may miss early on that they're infected, they could develop a chronic symptom if they don't know that they were immediately bitten. So you kind of have two slabs of patients. You have those that have been bitten and immediately go and will receive prophylaxis and ideally not be infected. And then there's some that may not really start feeling symptoms for years. So with all of these tests that you had listed earlier, the EPCR, IFA, the NanoTrap, how would you suggest patients go about looking to receive tests that best fit them where they are?
Right.
So basically, newly infected versus chronic.
So I'm going to do a little comparison now to the COVID pandemic. So everybody out there in the audience probably remembers at the beginning of the pandemic, the FDA came out and said, antibody bad for confirming current infection, right? And there's a reason for that, right? But PCR and antigen testing, good. Like, that's the way we need to do it. Well, why would they say that? And the answer is, after natural infection, what would you expect to find in the patient's bloodstream? Antibodies. And after vaccination, what do you expect to find in the patient's bloodstream? Antibodies. So for recurring infection, for treatment failure cases, for late stage infection, there's a big question among experts about whether antibody testing is reliable at all. And this is hugely controversial in Lyme disease, right? Whether, you have people on one side of it saying the false positive rate of antibody testing is leading people to believe that an infection is contributing to persistent symptoms. And the argument there is really it's immune dysregulation, which, by the way, doctors also don't, en masse know how to treat. And others, so post-infectious syndrome. And then there is emerging research that says, actually, in some people at least, some of these infections can persist and treatment failure is quite common. So in one study, I think probably the most rigorously designed study to date actually came from the Lyme Research Center at Johns Hopkins University that followed patients. Now, this is the tight definition of Lyme disease, people who had antibody testing and an EM rash and followed them over time, right? And found that, a couple of months after therapy, that 43% were still symptomatic. Those symptoms over time, like a lot of the COVID long hauler patients, that some portion of them were still sick a year later and had very debilitating symptoms. So it's literally taken their life down. And I think that's one of the most important studies that we have out there that really supports this idea, that persistent infection is absolutely possible. Did we blip?
You did briefly, but none of your words did. It was very
like
clean.
We froze there for a moment, Noah. We're back again.
Okay, we good?
Yeah.
Okay.
I think so. You're still frozen, but I can hear you. My signal's strong.
Okay, there you go. There you go. I think we're good. I agree. Right. I could hear you the whole time. There was some video malfunction, but there was no issue with your audio. So that's the most important part. We at Project Lyme very much agree that Hopkins is doing some great research. Another quick plug, Dr. John Alcott, who's the director over there, is going to be our keynote speaker for our upcoming gala. Anybody who's in the attendance, please check out our website he's going to do a lot of talking about the persistent symptoms that they have identified there. So great segue. I think, and it seems like I'm getting some feedback again here. Hoping not. Okay, are we good? Okay, moving on. For now. Appreciate your patience, everybody. Moving on to outlining usage. Obviously, you've talked a lot about the specifics of how the tests work and the research that you're doing at Galaxy. For patients, I want to clarify how they can get the tests and what your current fee structure might look like, because I'm sure we have a lot of chronic patients that want to go back to the testing block, or some people who are new to it and just want to really clearly define that they either have Lyme, Bartonella, etc.
Right. And so we're still in a place now where, you know, we don't have a lot of science to really drive testing recommendations, but our recommendations right now are to combine indirect detection, so antibody testing, with direct detection. It maximizes the diagnostic data for the clinician. A doctor's order is required on test orders, and there's a very good reason for that. Concern people self-treating with potentially harmful types of therapies. And so so we require the doctor's order to make sure the patient has someone trained to talk to about their test results. We are really, really small still. And so we require upfront payment for all patients except Medicare patients, where the rules work differently. But we require upfront patients, and then we do a courtesy claims filing. So we'll file an insurance claim with the provided insurance data to private cover and private insurance companies, but we're doing it on an outer network basis. And I've had a lot of questions about that, but the bottom line is we're not big enough to be interesting to insurance companies yet. And so that's why we're set up with those terms, but we are filing the claims, and we're seeing regular reimbursements. We got codes this year for our new tests. So for the Bartonella digital ePCR and for the Lyme nanotrap. And that's really exciting to know that patients are getting a reimbursement on whatever they're paying up front. And then I would say the other things that we're doing really to help patients understand is we're working with a CME partner, so continuing medical education partner. Invisible International has a lot of free accredited CME modules up there, and we've Dr. Breitschwert has contributed at least 6 now, and you know, various other experts in this area, scientists, are also contributing content to support, and we'll continue that relationship. We're, I think, well known in the testing world for really good customer service. Again, we're researchers, so we're really interested in working with physicians, our clinician customers, on specific cases, especially novel cases where there might be novel presentations of symptoms. And we're always happy to talk to patients, to direct them to resources, you know, that may be helpful to them. Especially case reports that align specifically with their symptoms can be very helpful for them to take to their doctor and have a good discussion about, you know, if and how the infection could be contributing to their illness. Is that kind of what you're looking for, Noah?
Oh, that was a perfect response, and very exciting to hear for the patient side that there is a possibility for reimbursement, because I know that obviously you have testing, then you have treatment, and it can all add up very quickly. So the fact that you're working with insurance providers on behalf of the patient, I think, is a really unique way that you're supporting their journeys. The last question I had about usage is not so much about the human side of things, but the animal side of things. Obviously, if people are getting infected by Lyme disease or other tick-borne diseases, it's likely that you live in an endemic area and your pets might be vulnerable as well. So I did see on your website that it mentions veterinarians. How big of a market is there for pet-based testing, and can people also order pet-based testing from your site?
Right. So, so again, the testing is available through veterinary medicine, and veterinary medicine works very differently from human medicine, right? So, the veterinarians order the test, they mark it up to cover the costs of drawing the sample and their administrative costs, and that's how human medicine used to work. But we have all sorts of rules now around doctors that can't do pass throughs, so patients have to have a relationship with the lab. I would say that I will say about the animal health testing is these are infections we share with our pets. And so this is something coming from a veterinary college of medicine, right? We feel very strongly because there's actually an occupational risk for these zoonotic vector-borne diseases we're dealing with. And that is that people who work with animals, like veterinary workers, farm workers who do animal husbandry, they're a much, wildlife workers, animal control workers, they're all at much higher levels of risk of exposure, transmission of some of these organisms. And they might not all know about which organisms they should be looking for, or what their exposure rate could be, and geographically around that kind of thing. But they're living and working with animals. And that, also suggests that pet owners are at higher risk. I mean, dogs are more likely to bring ticks into the house, right? And so practicing prevention is incredibly important. And knowing that if your dog or cat is diagnosed with a flea or tick-borne disease, and it's a disease people can get, that the people in your family may have been exposed as well. And that makes me think about, some of the cases we've seen where you have a kid who's diagnosed with mono, but they don't have any titers against Epstein-Barr virus. Well, that's a good example of a case where if, there could be exposure to a vector-borne agent, because the symptoms can look very similar, swollen lymph nodes, flu-like illness, aches and pains, fatigue. And so I think that that's one of the things we've worked really hard at Galaxy. We identify as a One Health company. And for those who don't know about the One Health movement, it is a global movement primarily among researchers who are studying disease at the intersection of animal health, human health, and health of the environment. And what a great poster child, flea and tick-borne diseases are, because they literally live like right dead center at that intersection, right? So I think that that's a really important part of our work and understanding. And we don't want to panic people, about the disease, but we want them to know about what the risks are, how to prevent, exposures. And if they do think there may have been exposure, that, we're here and we're working really hard to advance public health education for clinicians and patients and advocates to get the word out around what to look for, how to understand it, how to test for it, that kind of thing.
Very cool. Thank you. So I received one question from our community here, and I'll ask that before I move on to my last one for you. So this is from Brenda Horowitz. Hey, Brenda, hope you're doing well. Do you recommend doctors attempt to provoke the bacteria prior to running tests?
I think that is an area that we really need research in, because that is a very sensible approach. Some of the challenges there, though, are how are you provoking it? And so, and I don't know about you, but if I've got an infection, I'm a little reluctant to do steroid provocation. I don't want to lower my immune function. And so some doctors will actually do antibody provocation. Others, recommend exercise and massage and things like that. And there are anecdotal reports that they're seeing more direct detection results when they do those types of interventions. And there's some other ideas on how that could happen. We've talked to, at least one clinician, one of our top customers, around the potential for collaborating on research around that, which every single time, Noah, winds us back to who's going to fund it. Where's the research funding? Where's the research funding? And that's a lot of what has slowed progress in generating science to support that kind of intervention.
Well, hopefully one day maybe Project Lyme could look to partner with you all and further some research, because obviously we're looking to work on behalf of patients. So keep me in the loop with that. But I want to ask you one final question before we wrap up for today. I think you're a great person to answer this, which is, how would you describe the current state of tick-borne disease diagnostics?
So I will reflect then on my service on the diagnostics subcommittee for the Tickborne Disease Working Group and share that our committee basically came to the conclusion, after a deep dive into what was available, that there are a lot of very promising diagnostic approaches, but they're not receiving investment. And so they're trapped in universities, or they're trapped in small companies like Galaxy. So we really need, government funding to step up. There's obviously growing foundation funding, which is really what's driving the advances in diagnostics right now. And we really need investors to invest in the commercialization. There's a lot of focus on developing them, like getting them ready to go to market, but there isn't a lot of funding or support for taking those and getting them out actually into clinics. And so, for example, Galaxy, we don't have a sales and marketing department at all. Like literally, we have a team of scientists, and we're presenting at conferences, and we engage in a very close way with doctors to generate case reports and to get other retrospective data published, and we're applying for grants and stuff. But all of the advances we've made in 14 years has really been just by doing what we do and being willing to engage with patients and clinicians and the public to get this thing done. Imagine what we could do if we could get more fuel in the tank.
Yeah. I think that's a perfect summary. And that's exactly what we're working towards as an organization, is to find that fuel for the tank. And we're looking to partner with as many other organizations in the space as we can. There's a lot out there. The more that we can find ways to pool resources, I think the more that we're going to be able to benefit patients in the long run, which is really why we're all doing this work to begin with. So thank you so much, Dr. Elam, for taking time to spend with us today. I think you provided a lot of insight about the progress that's being made, and I hope that the patients watching this have some, positive outlook for the future of tick-borne disease testing. Really think that there's a lot going on here, and way more focus than there seems like there was even 5 years ago on this issue. So thank you for all of your work. Thanks again for taking the time to be with us today, and have a great rest of your evening.
Thanks a lot. Great work.
Bye-bye.